Welcome to Module 154, Chapter 12. So we're going into anesthesia. I think you guys are really going to enjoy this. It's one of my favorite chapters. I'm not going to say that about every chapter, I promise. I know I've said that quite a bit. I love E&M and I really enjoy anesthesia. It's just, to me, it's easy and fun and very interesting. So without further ado, I'm going to share my screen. Okay, I'm gonna wait for this to go up. There we go. So anesthesia, chapter 12. The anesthesiologist is a physician whose medical specialty is anesthesia. These specialists are often members of outside practices who report their services separately. Why is that important? Because your anesthesiologist and your surgeon are two different people in most cases. So that means if you're an anesthesiologist coder, you would code for anesthesia. And if you were surgery, you would code for your physician. The use of anesthesia creates a state of analgesia, the absence of pain. So you need to know that definition. That allows the patient to have surgery or other procedure performed without experiencing pain. The anesthesiologist's job is to administer medications that will induce general, regional, local, or conscious sedation in the patient while managing the life functions of the unconscious patient and directing respiratory or cardiac resuscitation efforts. So let's watch this little video.
If you've had surgery, you might remember starting to count backwards from 10, 9, 8, and then waking up with the surgery already over before you even got to 5. And it might seem like you were asleep, but you weren't. You were under anesthesia, which is much more complicated. You were unconscious, but you also couldn't move, form memories, or hopefully feel pain. Without being able to block all those processes at once, many surgeries would be way too traumatic to perform. Ancient medical texts from Egypt, Asia, and the Middle East all describe early anesthetics, containing things like opium poppy, mandrake fruit, and alcohol. Today, anesthesiologists often combine regional, inhalational, and intravenous agents to get the right balance for a surgery. Regional anesthesia blocks pain signals from a specific part of the body from getting to the brain. Pain and other messages travel through the nervous system as electrical impulses. Regional anesthetics work by setting up an electrical barricade. They bind to the proteins in neurons' cell membranes that let charged particles in and out and lock out positively charged particles. One compound that does this is cocaine, whose pain-killing effects were discovered by accident when an ophthalmology intern got some on his tongue. It's still occasionally used as an anesthetic, but many of the more common regional anesthetics have a similar chemical structure and work the same way. But for major surgeries where you need to be unconscious, you'll want something that acts on the entire nervous system, including the brain. That's what inhalational anesthetics do. In Western medicine, diethyl ether was the first common one. It was best known as a recreational drug until doctors started to realize that people sometimes didn't notice injuries they received under the influence. In the 1840s, they started sedating patients with ether during dental extractions and surgeries. Nitrous oxide became popular in the decades that followed and is still used today, although ether derivatives like sevoflurane are more common. Inhalational anesthesia is usually supplemented with intravenous anesthesia, which was developed in the 1870s. Common intravenous agents include sedatives like propofol, which induce unconsciousness, and opioids like fentanyl, which reduce pain. These general anesthetics also seem to work by affecting electrical signals in the nervous system. Normally, the brain's electrical signals are a chaotic chorus as different parts of the brain communicate with each other. That connectivity keeps you awake and aware. But as someone becomes anesthetized, those signals become calmer and more organized. suggesting that different parts of the brain aren't talking to each other anymore. There's a lot we still don't know about exactly how this happens. Several common anesthetics bind to the GABA-A receptor in the brain's neurons. They hold the gateway open, letting negatively charged particles flow into the cell. Negative charge builds up and acts like a logjam, keeping the neuron from transmitting electrical signals. The nervous system has lots of these gated channels, controlling pathways for movement, memory, and consciousness. Most anesthetics probably act on more than one, and they don't act on just the nervous system. Many anesthetics also affect the heart, lungs, and other vital organs. Just like early anesthetics, which included familiar poisons like hemlock and aconite, modern drugs can have serious side effects. So an anesthesiologist has to mix just the right balance of drugs to create all the features of anesthesia, while carefully monitoring the patient's vital signs and adjusting the drug mixture as needed. Anesthesia is complicated, but figuring out how to use it allowed for the development of new and better surgical techniques. Surgeons could learn how to routinely and safely perform C-sections, reopen blocked arteries, replace damaged livers and kidneys, and many other life-saving operations. And each year, new anesthesia techniques are developed that will ensure more and more patients survive the trauma of surgery.
So pretty interesting, right? Anesthesia is so important for advancement in modern medicine. And that's just one of the things that I've never really thought about until I saw that little video, and I really started to ponder what a miracle it actually is to be able to be put under and go through surgery with no pain. Here is a list of commonly used anesthesia terms: endotracheal, epidural, spinal, general, regional, and local. I would like to point you to the right pages in your textbook. If y'all saw me moving around a little bit, I was trying to get books open to the correct pages. So in the 2019 edition, on page 323, you're going to find the definitions for those. And then in the 2020, it's 338. You're going to need to know what these mean. So let's talk about methods of anesthesia. Endotracheal, sorry guys, means through the mouth. And as you can see that they are going through the mouth with their little apparatus there, their tool. There's local application, and it's the application to the area, injection or topical, with local anesthesia and anesthetic agents such as lidocaine is directly applied to the area involved as a topical anesthesia, or is administered by local infiltration through a subcutaneous injection as, okay, I need to get to the bottom of that, shown in figure 1212. So if you look at, let's see, I'm looking for 1212 right now. Well, you guys have your textbooks. Look at figure 1212. I don't have to give you those page numbers. You can find that yourself. An epidural means into the epidural space. Regional means field or nerve, includes spinal and epidural. So you ladies who have had babies, some of you have had epidurals, so we know about that. That's the picture on the right-hand side where they're actually getting the patient ready for the epidural. Then there's patient-controlled analgesia, which is PCA. Patient administers the drug, often used to control acute post-op or chronic pain. You guys know when you have a major surgery, I don't know if you know or not, whenever I had my hysterectomy, I had one of these machines, and every 15 minutes I could push the little apparatus and it would give me my medication, but it would only give it in certain increments at certain times. So let's talk about moderate conscious sedation. Conscious sedation provides a decreased level of consciousness, but does not actually put the patient to sleep. The patient can breathe without assistance and can respond to stimulation and verbal commands. Nonetheless, a trained observer must be present to assist in monitoring the patient. Codes 99151 through 99153 are used when the same physician performing the procedure performs the conscious sedation. So go ahead and look those up in your CPT. Then you've got codes 99155 through 99157 are used when the conscious sedation is performed by a different physician. So how is the anesthesia section formatted? These codes are organized. The first major subdivision is based on anatomic site. The second subdivision is based on the type of procedure performed. However, there is an exception to this. The last four subsections in anesthesia are radiologic procedures, burn, excisions or debridements, and other procedures. So those are not going to be organized by anatomic site. It's just by procedures. Okay, so let's take a look at this. So under CPT code 01200, that's the upper leg except for the knee. And the type of procedure is hip joint. Then 00400 is broken down into integumentary system on the extremities. But that's the lower leg. Below knee includes ankle and foot. So that to me just sounds a little confusing. So I want you to go ahead and open up your CPT books. I'm going to hold mine up here. And I want you to look at CPT code 00100. Well, if you look above, your category is going to be head. But this is anesthesia for procedures on salivary glands, including biopsy. So it goes all the way. 00102 is repair of the cleft lip. 00103 is the eyelid. 00104 is electroconvulsive therapy. Then it just keeps on going. The middle ear, the external ear. Corneal transplant. Radical surgery of the nose. So it's just different ones. And we're going to do a little bit of practice in coding this, and it's not going to be hard. But that is broken down under a head, and that's your anatomic site. And then it goes into the different procedures. You'll also see on that same page that the neck is there. You guys, it's not going to be hard to code this, I promise. So there is an anesthesia formula. It's base units plus time units plus modifying units. The CPT codes for anesthesia services include preoperative, intraoperative, and postoperative care. Anesthesia services are billed according to a standard formula for payment that is generally accepted throughout the United States. Again, that formula is base units plus time units plus modifying units and times the conversion factor. So B is for base unit. The Relative Value Guide, RVG, contains codes for anesthesia services, most of which are included in the anesthesia section of the CPT. The purpose of the RVG is to compare the complexity of various anesthesia services so that the relative value of each service when compared with all services may be assigned. The basic unit value for a service is this RVG value. I do not have a relative value guide. If you go to work for an anesthesiologist, they're going to give you this guide. Just know for test-taking purposes, you're not going to be using this formula, but we just want to hit it as a basic information. So here is an example of the base unit value. So we were just talking about our anesthesia under the head category, 00100, and that was anesthesia for procedures on salivary glands, including biopsy. So let's look what our base unit would be, value would be on this. So 00100 is a base unit of 5. 102 is 6, and there, so on and so forth. So this is where that base unit comes from, is that guide. They're just giving us an example of the guide right here. So T is for time. Time is measured from the beginning of the preoperative period, when time is spent preparing the patient to receive anesthesia, through the time when the patient ceases to be under the care of the anesthesiologist during the postoperative period. This time is recorded in the patient's record. The amount of time represented by a unit varies for different carriers, but typically will be 15 or 30 minutes. So here's an example. Patient record indicates 15, 30, or 60 minutes. They're often broken down into 15-minute increments, which means 1 unit. So every 15 minutes equals 1 unit. So 15 minutes is 1 unit. 30 minutes is 2 units. 60 minutes is 4 units. So every 15 minutes equals 1 unit. So this is just to reiterate what we just said. Anesthesia begins with the anesthesiologist to manage patient in the operating room pre-op, then continues through intra-op, then ends at post-op whenever the patient is no longer needed to be under the care of the anesthesiologist. For example, anesthesia time started at 9 a.m. and the patient was discharged to the PACU at 1:30 p.m. and that would be 270 minutes. So PACU stands for Post Anesthesia Care Unit. So M is for modifying units. So modifying units reflect circumstances or conditions that change the environment in which the anesthesia service is provided. Physical status modifiers are an indicator of the level of complexity of the services required to treat that patient. So let's talk about physical status modifiers. Where are these going to be found? Well, if you look on the back of the front cover of your CPT, you're going to see P1 through P6. Those are anesthesia physical status modifiers, and that's where you find those in your CPT. Okay, so to continue on with that, P1 is normal healthy, P2 is mild systemic disease, P3 severe systemic disease, P4 severe systemic disease and in constant threat of life, P5 not expected to survive without operation, and P6 is brain dead. How do the relative values of physical status modifier P4, P5, and P6 differ? P4 is assigned a value of 2, P5 a value of 3, and P6 is a value of 0. Recall that a patient with a P3 status has severe systemic disease, but it is not life-threatening. It is assigned a value of 1. P3, P4, and P5 are steps on a scale that describe the impact of patient condition on anesthesia services. P6 is assigned a value of 0 because the patient is clinically dead and cannot benefit from extraordinary services. So you can actually write beside your physical status modifiers those value numbers if you'd like, but I'm just letting you know past this point you won't be tested on that. So another modifying unit, qualifying circumstances, 99100 through 99140. This can be found not only under 99100 in your CPT, but you can also reference those very quickly in the anesthesia guidelines. They're also in your medicine section, and you can't report these for Medicare. So let's take a look at what the qualifying circumstances include. 99100, anesthesia for a patient of extreme age or younger than 1 year and over 70. Relative value 1. 99116, anesthesia complicated by utilization of total body hypothermia. Relative value unit 5. 99135, anesthesia complicated by utilization of controlled hypotension. Relative value unit 5. And 99140, anesthesia complicated by emergency conditions. Relative value 2. So again, if you want to write your relative value units beside those, you absolutely can. I just want you to know I'm not testing you on if you can figure up this formula. So again, here is a little bit, it's listed a little bit differently here. This is more like when you look in your CPT manual in the medicine section, but we just went over those, so we're not going to do that again. Which qualifying circumstance has the greatest impact on the relative value of the modifier? Well, let's look at 99116 and 99135. Each have a base unit value of 5. So those two circumstances or qualifying circumstances give us the greatest impact. One is for hypothermia and the other one is for hypotension. So the use of hypothermia or hypotension will have the greatest impact. In both cases, the patient's heart rate and respiration are slowed markedly, as they would be if these conditions were achieved accidentally. The threat to the patient is greater in these cases. The level of services required is greater, and the relative value must therefore be greater. So let's do a summation of the formula. Base units comes from the RVG based on CPT codes. Time units, often 15 minutes equals 1 unit. Modifiers or qualifying circumstances are 99100 through 99140 and are your physical status modifiers. So it would be B plus T plus M equals units times your conversion factor. Well, I think the next slide is going to tell you about your conversion factor. Well, I'm going to go to conversion factor first, then we're going to go back. So this is your conversion factor. It has to do with the locality or where you're located. So they did Manhattan, New York City, Queens, the rest of New York, North Carolina, and North Dakota. So now let's go back to our scenario. An 84-year-old female with severe hypertension had a 4-centimeter malignant lesion removed from her right knee. The total time of anesthesia services was 60 minutes. The medical record indicates that the patient's physical status was P3 for severe systemic disease. So how many time units were delivered if a time unit is 15 minutes? What modifiers apply and what is their total value? So the patient was treated for 60 minutes, which means 4 time units. The patient is older than 70 years of age, warranting the use of qualifying circumstances, which is code 99100, which is a value of 1. The patient has severe systemic disease, which is a physical status modifier of P3, which is a value of 1. The total modifier value is 2. What they're going to do is they're going to take that 99100 and the P3 and they're adding that together. So what do you have? You have a 4 plus a 2. Then you have to add whatever your RVG is for your CPT code. What anesthesia are you going to be using? So it didn't go that far, but I just want you guys to see the example and how they're actually adding that formula. Then say that you had a total, let's just pretend that the CPT, the units were going to be 3. Then we had 4 time units. Then we have 2 modifier units, so that's 3 plus 4 is 7. So we have a total of 9 units. So let's go here. Let's say that we're living in Manhattan, which is 24.65 as your conversion factor. So I'm going to write that down. 24.65 is our conversion factor, and our units are 9. So what would our anesthesiologist make? So you would take 9, which were our units, times 24.65 equals $221.85. So that's what our anesthesiologist would be paid for that scenario. So I hope that makes sense, but I don't want you guys to get your mind real boggled down with these units and the formula, because I'm not putting that on the test. And it's not going to be on your NCCT either. So this is a little bit more in depth, so let's watch this.
All right, so what we're going to talk about is how to calculate anesthesia fees. When we start calculating anesthesia fees, what we need to, it's a very simple calculation where we take the total units of the and we multiply that by our conversion factor. What we have to calculate first is what our total units are, and there's several different things that go into that. Every single CPT code or every single anesthesia CPT code has its own basic value that's been assigned to it. There is a table that shows you what those anesthesia codes are in the back of your book, and you'll look up the code there. Then we look at time units. A time unit is based off of 15 minutes. How long was the patient under anesthesia? Then we have to look at the patient's physical status. We know that we have P1 through P5, and based off of the patient's physical status, we'll determine what P code they have. Not all P codes will have a value placed to it. Then we have the qualifying circumstance. Those are the qualifying circumstance codes, and those have also been assigned a base unit or a base value based off of what that particular code is. So when we can figure that all up, then we can go ahead and take our conversion factor, which is given to us by CMS, and it is based off of the locale where that conversion factor is. So let's start with an 86-year-old gentleman who was placed under anesthesia for 30 minutes. So there's our time unit. So there, he was placed under anesthesia for 30 minutes. And we know that our units for that is calculated at 15 minutes per unit. So if we were under anesthesia for 30 minutes, that's going to give us 2 units. The code that was charged by the anesthesiologist was 00300. And we know that that basic value for 00300 is 5 because we found that in our appendix. Also, the patient recently had an MI. So because he had an MI, the physician said that he had a physical status of a P3, which means that the patient has severe systemic disease. Because he has severe systemic disease, that we can add another basic unit value to that. Then we also look at this qualifying circumstance. Because our patient is over 70 years old, he's 86 years of age, we can use 99100, which means that we have a patient of extreme age. That also gives us another unit. So now, once I have found these 4 things, I can now add up how many total units that we are going to multiply our conversion factor by. So 5 plus 2 plus 1 and 1 gives us 9. So I have a total units of 9. So my conversion factor, because this patient was in Birmingham, Alabama, and we look at our graph, tells us that our conversion factor is 21.37. So what I simply need to do is take my conversion factor of 21.37. I'm going to multiply it by the total units that I calculated for my patient, and when I do that, I come up with $192.33. So the fee that the anesthesiologist will charge the patient for being under anesthesia for 30 minutes with a CPT code of 00300 is $192.33.
So I hope that that makes a lot of sense to you. Again, I just want you to understand what the formula is, but I'm not going to be testing you on it. So let's talk about anesthesia for multiple surgical procedures. How are anesthesiologist services coded when multiple procedures are performed, and why? The code will be based on the most complex procedure performed because the services delivered will be matched to the most complex surgical procedure. Codes for each of these procedures delivered will not be used because they occur within the span of a single anesthetic delivery. The inclusion of multiple procedures will, however, increase the total of time of the procedure. So let's just think about that. I'm going in to have my appendix removed. I'm put under to have my appendix removed. They get in and they see, oh goodness, she has her gallbladder is completely gone. And so they take out my gallbladder and say they find a couple of more little things that they're going to do. Well, you're not going to charge that anesthesia CPT code for every single one. You're just going to do it for the most complex. And that would be, I would say, let's say the appendix removal. But what's going to increase the money that he makes is the fact that the time is going to be longer. So he'll get paid for his time. I hope that that makes sense too. Once anesthetized, length of time, not number of procedures. That's a great way to think. Remember that. Once you've been given anesthesia or they've given anesthesia, it's the length of time, not the number of procedures. Okay, this is going to illustrate how basic units would be calculated for a case in which two procedures of varying complexity are delivered. One 10 base unit value, the other is 5 base unit value. So one of the CPT codes gets a 10, the other gets a 5. You're only going to report the 10 because it's more. So I hope that that really, really clicks with you guys. So we're going to talk about more modifiers. Anesthesia does not just carry CPT modifiers. It also carries HCPCS modifiers. And that is the little purple book. It says Bucks HCPCS Level 2 codes. And so you're going to have a section of modifiers in there. So this is what I would like for you to do. I would like for you to take this list. I would like for you to get into your HCPCS manual. I would like for you to tab where the modifiers are found and go ahead and highlight these modifiers. How are the HCPCS modifiers used in the coding of anesthesia services? These modifiers define the types of providers involved in the care of the patient. They prove additional information about the services performed that will be important to the third-party payers who are processing claims for reimbursement. Now, I am going to go back one slide and give you an example. An AA, which is the one who is the modifier that is used the most often, is anesthesia by anesthesiologist. Let's look at QX. CRNA, Certified Nurse's Assistant, directed by physician. So, and you have a couple of different options with your CRNAs. So that's what they're talking about. It's going to tell them who actually administered the anesthesia. Look at AD, physician, medical supervision, 4+ concurrent procedures. So you have to have 4 or more things being done to use that. Okay, I'm not doing that. So that is the end of anesthesia coding lecture. And you guys, I'm going to be giving you a coding packet that will be on Friday the 2nd. I am actually going to do a couple of those problems for you on the board, and I'm going to upload that video for that day. Also, we're going to be doing the integumentary system. No, I'm sorry, strike that. We're going to be doing the muscular system to go right behind the skeletal system. So I hope that you guys understand the anesthesia section. It is going to be very, very important that you get in, you read, and you do your exercises. I want to point out, you guys need to make some study materials for those vocabulary words or those key terms that we talked about. The endotracheal, epidural, spinal, general, regional, local. It's going to be very important for you guys to know those things. If you have any questions, let me know. Have a good day.